Okay. All right. So now we're getting to the flashcards. We have about 10 minutes or so. So, duloxetine, right?
Mhm.
SNRI, diabetic neuropathy, fibromyalgia, chronic musculoskeletal pain, chronic depression, increased descending serotonin norepinephrine inhibition. So they get nausea, sweating, blood pressure affects serotonin syndrome, um, and hepatic risk. Gabapentin, pregabalin, alpha 2 delta calcium channel ligands that reduce excitatory neurotransmitter release. Um, One thing they didn't put here is blurry vision. That's another side effect I'd be mindful of for the boards, okay?
Okay.
Um, Tricyclics, amitriptyline, nortriptyline. Those are the two most common ones we use. I'd say probably because they have the least anticholinergic side effects and they have the most utility in pain. Alpha 1 blocking, cardiac sodium channel blocking. Avoid use cautiously in elderly, BPH. And so just quickly, how do you manage a tricyclic overdose?
Um, Tricyclic overdose isn't it just supportive? Like you have to
Yes, but there's more than that.
I mean I know like the EK you know you have to get an EKG and stabilize them cardiac wise and um like fluids they would go to
So
the ICU.
ABC is like right airway, all that. You could you give activated charcoal for the
Okay.
airway, and that may be effective for up to 2 hours post-injection, especially if the bowel sounds are diminished. You want to minimize the formation of acidosis, and as it may increase cardiac neurological toxicity. Seizures usually respond to benzodiazepines, but if refractory, prompt administration of anticholinergics such as phenobarbital or propofol, or even general anesthesia should be considered. Sodium bicarbonate should be given to hemodynamically unstable patients, patients with seizures, or those with QRS prolongation of more than 100 milliseconds. Sodium bicarb should be given as a bolus of 1 MBq per kilogram, followed by IV infusion containing sodium bicarb. The aim of the therapy is to narrow the QRS to keep the serum pH between 7.5 and 7.55. Hypotensive patients should be treated with IV fluid, sodium bicarbonate, and if their hypotension does not respond to this alpha adrenergic agent, such as an alpha adrenergic agent such as norepinephrine should be used. And sodium bicarb could treat the dysarrhythmias. Temporary pacing may be used to treat refractory symptoms. And bradycardia not responsive to sodium bicarbonate. Physostigmine, type 1A, 1C, and type 3 antidysrhythmic agents should be strictly avoided. So, flumazenil, avoid. Intralipid emulsion treatment should be considered in hemodynamically unstable patients with overdoses of lipophilic tricyclic antidepressants, since they are highly protein bound with extensive volume of distribution, and enhanced elimination with dialysis and hemoperfusion is not effective. So I'm going to send you this reference I just read off of,
Okay,
um,
awesome.
just so you could also read it for yourself. Okay, next, carbamazepine, right? So first try line of therapy for the trigeminal neuralgia, toxic dizziness, diplopia, ataxia, hyponatremia, SIADH, leukopenia, hepatotoxicity, CYP induction, Stevens-Johnson syndrome. Okay,
Okay.
triptans. For acute migraines, avoid ischemic heart disease, stroke, TIA, uncontrolled hypertension, significant vascular disease, hemiplegic uh, basilar migraine. Frequent use may contribute to medication overuse headaches. CRGP monoclonal antibodies prevent migraine therapies targeting CGRP ligand or receptor. Erenumab is associated with constipation, possible hypertension, and it's not acute abortive therapy. It's useful after failure and tolerance of conventional preventative therapies. Botox, chronic migraine prevention, not abortion, acute abortion. Chronic migraine over 15 headaches per month over 3 months, and migraine with features over 8 days. It could cause neck pain, ptosis, focal weakness. Ketamine, NMDA receptor antagonist. uh, reduces wind-up, central sensitization, opioid tolerance, hyperalgesia, adverse effects, dissociation, hallucinations, hypertension, nausea, hypersalivation. Be careful with cardiac issues or psychiatric issues. You know lidocaine, so I'm going to move on from that one. Methadone, we talked about. Um, I do have a uh, article that I had earlier. Let's see if I can find it. Um, on methadone withdrawal, because methadone withdrawal could be something that is biphasic and a little complex. So
Yeah.
I'll try to send you this.
Okay. That'd be great.
Let's see, here it is. Yeah, there's a case report, so but it has some details about it. So I'll just text that over to you. Okay.
Okay.
Buprenorphine. Remember, high partial mu agonist and kappa antagonist. Okay.
Okay. Yeah. I-
Opioid, we know about the GnRH. We talked about that last time. I'm moving a little quicker because we have another couple minutes left. COX inhibits the prostaglandins. Acetaminophen toxicity, always think of NAC and acetylcysteine. Steroid side effects, we talked about this many times already, particulate versus non-particulate as well. Intrathecal gadolinium, encephalopathy, seizures, contrast allergy. Last, once again, intralipid, avoid propofol, use benzos, ACLS. I always refer to ASRA guidelines for neuraxial procedures or anything
Uh-huh.
to do with just of note, in the past, ACIP considered caudals low risk and did not really recommend stopping anticoagulant therapy, but I think there's conflict in the literature. I think ASRA might be a little different. I'd have to look that up. They probably won't ask you that, but just something I thought would be interesting to know.
Okay.
Um, DRG, it's a focal neuropathic pain distribution. Okay. More of the extremities, groin. You can use it for back pain. It definitely can work for failed back and back pain. It doesn't have to be just a one particular nerve or dermatome, but that's the more classic indication, and that's usually where they test.
Okay.
Ziconotide, non-opioid N-type calcium channel blocker, no respiratory depression or opiate tolerance, but it's contraindicated in psychosis. Granuloma, catheter tip mass, high dose, high concentration intrathecal opiates, usually morphine. Celiac plexus block, we talked about last time. Hypotension, diarrhea. Superior hypogastric plexus block. It's for pelvic viscera. The ganglion impar is just more perineal coccygeal. SI joint, it's really, you need to do different provocative maneuvers. The compression test, Faber's, Lessegs maneuver, all these maneuvers you can look up if you don't remember them. And you need to do a diagnostic test before you treat. Just a caveat. Typically, the patients will have referred pain down the leg, but typically there won't be sensory abnormalities like numbness or weakness, right?
Yeah.
We talked about facet innervation, vertebral augmentation. Um, Be careful with infection, uncorrected coagulopathy, burst fractures, retropulsion, neurocompression, and cement leak is a risk. What is a common side effect of vertebral basilar nerve ablation?
What is a common side effect? I don't know.
Radiculopathy. When you're going in, you
Oh, okay.
complete the nerve root. And if that happens, you could do an epidural, give a Medrol pack. Budapest criteria, we talked about last time. Fibromyalgia, we've talked about central sensitization syndrome. The shopping cart signs, cervical myelopathy, core dysfunction, hand clumsiness, gait imbalance, hyperreflexia, upper motor neuron signs, right? Hoffman, Babinski, bowel, bladder changes, and this is a surgical case, usually.
Yeah.
Corticaina also could be a surgical case. EMG, you have that article. I'm going to let you look at that yourself. But it could take weeks. I think more than 3 weeks. I remember 6 weeks being until it gets abnormal, but maybe the early findings can be present in 2 to 3 weeks.
For
Um,
the test, would you say two
I,
or
I
six
would I would
or
look at that article. It's going to say the article I sent you will give you the best answer.
okay,
Off the top of my
okay,
head, I really don't remember. Um, So,
okay.
yeah, reduced snaps, normal if the lesion is proximal to, they're normal if the proximal to the dorsal root ganglion, but if it's reduced, the amplitudes, it's going to be peripheral to the neuropathy, peripheral neuropathy, plexography, or lesion distal to the DRG. Axonal, lower amplitude, demyelination, slower conduction velocity, prolongs distal latency, causes conduction block, temporal dispersion, and basic pattern recognition is board relevant. Myopathy versus neurogenic EMG. Myopathy, short duration, low amplitude, MUAPS with early recruitment. Chronic neurogenic reinnervation, there's large amplitude, long duration, and motor unit action potentials with reduced recruitment.
Okay.
Methemoglobinemia, well, it oxidizes hemoglobin to iron 2 plus iron to iron 3, which impairs oxygen delivery, um, caused by benzocaine, prilocaine, signs of cyanosis, chocolate brown blood, pulse ox 85%, saturation gap. Treat symptomatic cases with methylene blue. And lastly, common peroneal neuropathy, foot drop after leg crossing, compression of the fibular head, weak dorsiflexion, eversion, relatively preserved inversion favors peroneal neuropathy over L5 radiculopathy. And just to note, this is why we don't do the inferior lateral genicular nerve ablation, right? To avoid that peroneal nerve, which is
Yes.